Okay, guys, we'll get started. We'll finish up immunity and inflammation today, and then tomorrow we'll get started with cardio. So just to review what we finished off yesterday, now we're getting into the disease processes, or when people have a hypersensitivity reaction to things, what goes on. And as you go through different classes, especially you get to like derm, you get to some of these hypersensitivity reactions, they're just going to say it's a type 3 reaction. You have to know what that is. So again, the mnemonic acid, A for type 1, which we've already gone through, which is the A to P in anaphylaxis. Allergic, so type 1, the A for acid, remember all the different things. Allergy, A to P, anaphylaxis for type 1 hypersensitivity reactions. And we went through all that. Remember, eczema, atopic dermatitis due to an hypersensitivity reaction, and it shows up on the skin. Anaphylaxis is the more severe form of it. Tissue swelling, compromised airway, can't breathe anymore. Anaphylaxis, those are the ones you gotta be careful for and watch out, make sure their airway is secure. This is where you got all these urticarias, angioedema, swelling of the lips and the tongue. But if they only have a rash, this urticaria from an allergy, I want to say it's better than the anaphylactic one, obviously. If it's just a skin reaction, you get some hives, take some Benadryl and it goes away, that's okay. But when it starts getting worse, every repeated exposure, then that risk of anaphylaxis goes up. So with repeated exposures, or every time you get exposed to those problems, you have an overreaction or response to that pathogen, antigen, whatever it is, and our body doesn't know how to react to it, and we have a hyper response, and that's what we're learning about today. So drugs, we talked about, insect venom, latex, foods. Like I'm allergic to like fire ants and like bee stings, so if I get stung with those, my hand swelled up. Or one time when I was in PA school, I got stung and I had like a track line coming up my arm, like a red line. So I like go to hospital and get IV stuff for that. But I never had like a breathing issue or anything like that. So knock on wood. But okay, so then more pictures of anaphylaxis, laryngeal edema, and so on and so forth. Now moving on to the second type. This is type 2. This is antibody mediated or cytotoxic. And let me just make a sticker. So cytotoxic is the C. These are mediated. Let me change this color so it doesn't show up very well. IgM or IgG to cell-bound antigen. So this is cytotoxic. This means cells have to touch. So think of it that way. Cells have to touch. And let's talk about what are some of the most common ones. Destruction of the host cells by agglutination. What is agglutination? Clumping of what? Red blood cells. Why are they clumping up? What happened that would cause? Well, if you're given a transfusion of blood by someone else that you didn't type and cross for, you have those opposite antigen antibodies on the red blood cells. They're going to clump together and cause agglutination. Cell to cell touching. Red blood cells are touching each other. That causes this cytotoxic. Phagocytosis, the white blood cells are eating and touching other cells. They're touching them. Lysis of the cell membrane. Remember, all that stuff inside is, not actually the healthiest stuff. And if you ever did like blood draws, and when you got a traumatic blood draw, what does that mean? What happened to all those red blood cells? They lysed, they broke up. And how do you know you did that? When you spin it, instead of it being nice and light clear, it's now pink because all the red blood cell, all the pigment left the red blood cell. And when you spin that tube down, that serum that should be like that straw color is a little bit red now because all the hemoglobin left the red blood cells and got out. Same thing here. You're lysing those cells, you touch them, and they explode. Red blood cells are the common targets. That's why a lot of it, we talk about these transfusion reactions. Rh, hemolytic disease of the newborn. That's that Rh factor in the newborn. Remember, sometimes you can have mixing of the blood. So what do we do for pregnant women before they deliver a baby if they are Rh negative? RhoGAM. What does that do? Why do we give that? What is it going to inactivate? The antibodies for the positive antigen. Rh, hemolytic disease of the newborn, is happening, again, that second baby, where those antigens could be there and attacks the second baby. Those are the big ones when it comes to that. So here's that hemolytic disease of the newborn. Again, has to do with those antibodies for that D antigen. Any questions on type 2? So type 2 is cell. Just think of red blood cells touching, agglutination, transfusion reactions. Cells have to touch. The next one is type 3, and this is the I, and this is immune complex mediated. This is where the antigen binds to the antibody and they make a complex called an immune complex. Okay, so these antigen-antibody complexes, those complexes now can get lodged inside the cells. And depending on what cells they get lodged into, that's where you have your problems surfacing later on. Examples, serum sickness, glomerulonephritis, and lupus. SLE is systemic lupus erythematosus. We're going to talk about that by itself a little bit later on in the lecture today. So, serum sickness, after injection with an antitoxin produced in an animal, you can get this type of rash. This is serum sickness. So that is type 3, but again, lupus, we're going to talk about in a little bit later, talking about these immune complexes that get lodged into your tissues. Type 4 is T cell mediated, also known as delayed, and this is the D one, delayed. This is mediated by T lymphocytes and macrophages. We get antigen deposition, activation of our T cells. T cells get activated, cytokine release, macrophages activation, and we get our inflammation. This is delayed because it takes about a day to 2 days before you start seeing the effects of this hypersensitivity reaction. This is usually caused by intradermal, epidermal, and dermal antigens, so things in contact with your skin. Allergic contact dermatitis, poison ivy, and poison oak. These are type 4 reactions. You may go hiking, walk through the woods, and like 2 days later, you have an eruption on your leg where you touch the poison ivy. It's a delayed response. Nickel, formaldehyde. I talked about nickel yesterday or on Tuesday. Cheap jewelry has nickel in it. It reacts with your skin turns green where that jewelry came in contact with your skin. It's a type 4 allergic reaction. There's another one that's a type 4 reaction that you all had to do before you came into PA school. TB test. Okay? You put a little bit of TB under your skin and you want to see, do you have a reaction to the skin where you injected the TB? If you get swelling and all the other things, that means you have a hypersensitivity reaction, which means you've already been exposed to TB. Your body knows what to do, and it causes a reaction. If you've never been exposed to TB, your body should not know how to defend against it because you've never been exposed, you don't get a reaction. Now, if you're from another country, if you ever notice some people have like a mark on their shoulders, that is a TB injection that was given in other parts of the world. If you have that type of vaccine, you can't do the TB test because it'll come back positive every time. Because the way they inoculate you for TB, they actually give you a little bit of it. We don't do that over here. So that's one reason why you can't do the PPD test for TB, if they have that. But again, those are all delayed reactions. 24 to 48 hours, do you see a reaction or not? No, then you're okay. Okay, so here's rust dermatitis, here's your poison ivy, poison oak, all that stuff. And this is the reaction. Again, it's localized to the part of the skin that was touched by that offending agent, the poison ivy. So again, just a review, here is the way to just differentiate all 4 of these hypersensitivity reactions. So this is a good one to remember. So just remember acid, allergic, cells, immune complex, and then your delayed type. Okay? Those are the 4. So as you're going through different classes, again, they're going to say this is a type 2 hypersensitivity reaction. Again, this is more like a definition lecture, so you understand what these words are. So when you see it again, you know what it is. So we're going to talk about now some selected disease states. The first one is, like I said before, we're going to talk about lupus. Systemic lupus erythematosus, chronic, why is this not ready now? Chronic inflammatory disease, characterized by relapses and remissions. So they'll be fine for a while, then they have a relapse, and they have symptoms that show up for a little bit, then they recover from those, and then they're in remission again, and everything's okay. And then they may have another flare-up, and that's a relapse. So that's what that means. Can affect virtually every organ system. So I mentioned before about lupus. What type of hypersensitivity reaction does lupus fall under? 3, which is what? Immune complexes. And I said that with these immune complexes, they can get deposited into any tissue in the body. So with lupus, because it can go anywhere in the body, no 2 cases of lupus present the same way. It just depends on where those immune complexes got lodged. If it's in the kidneys, they're going to have kidney problems. If the immune complexes go into the heart, they're going to have cardiomyopathies. If it goes into the vessels, they may have arteriosclerosis. Depends on where those things go. Considered an autoimmune, or also known as a collagen vascular disease, but it's an autoimmune. Our body's attacking itself, essentially. So again, symptoms. Could be anything. Whole bunch of them. Now, on a test, I'm not going to say they have these symptoms. What could it be? That's too generic. It's not enough information. I'll probably ask something different. Like, a person has lupus, what type of reaction would that be? Stuff like that. I can't just say they have breathing problems and fatigue and they're coming to see you. Do they have lupus? That's way too hard. You're missing a lot of information for that one. So again, pleural effusion, heart problems, lupus nephritis, arthritis. These are just if those immune complexes get deposited into those tissues. That's what it could do. But this is very pathognomonic for lupus, is this butterfly rash. And I'm going to outline what I'm talking about. That looks like a butterfly. Okay, it's called a butterfly rash or a heliotrope rash. On the face, that's usually, if they have stuff like that, usually, I'm not saying 100% of the time, but it's usually pretty likelihood that they have lupus if they have that type of rash on their face. Okay, so what's going on? Either we have excessive helper T cells or defective suppressor T cells. And what happens is when you have excessive helper T cells, remember, what do the helper T cells do? They're antigen presenting cells. They take the antigen, they present it to the B cell and say, this is what we're fighting against. Make your antibodies to kill this. If we have too many helper T cells, we're going to have an exaggerated response, right? We have way too many helper T cells. We're going to have an exaggerated response to an antigen, or defective suppressor T cells. Again, those are the killer cells. They're not going to be able to kill anything. So the antigen is going to present itself longer because the T cell can't get rid of it. So what happens is you get hyperactive B lymphocytes that synthesize a lot of autoantibodies against tissues. So that's where this immune complex starts. Either we have defective suppressor T cells or a lot of helper T cells, causes this hypersensitivity reaction. It's an overreaction. So again, since the autoimmune system normally does not attack itself, now we have a dysregulation, a problem with our immune system, this loss of self-immune tolerance. We can start attacking ourselves. So our native tissues are rendered foreign by exposure to other agents. So what you're going to find out as you're going through your diseases, some diseases will start with some event that happened a few weeks before. So when you're doing your history, they're coming in today. They may have been sick 2 months ago. So were you sick in the last 3 months? Because if they had Epstein-Barr, which is mono, and 2 months later, they're coming in with lupus issues, let's say, or some other problem, the Epstein-Barr triggered the event that caused this loss of self-immunity. It's an underlying insult. What do you guys learn about with the heart, with rheumatic heart disease? Okay, you're looking at someone who was sick as a child with rheumatic fever, and then later in life developed rheumatic heart disease from that insult from years ago. Some of the heart issues, they get cardiomyopathies. Some of them happen just because you were sick, you had a viral infection years ago that attacked the heart, and now the heart is getting weaker and weaker. So sometimes you have to ask about their history. Were they sick recently? Any sick contexts? You'll do that a lot with ENT. Obviously, sore throats, all that stuff is communicable. So you'll learn about all that stuff in that class. So usually there's going to be some sort of insult to the system that happened beforehand, environmental agents, something that can cause this loss of self-immune preservation that causes this whole thing to happen. So with lupus, yes?
What did you write underneath the auto?
Oh, I just wrote this. It's just that. I just wrote that. And against native tissues, I just started writing it, but it was already written, so I stopped. So we have autoantibodies have been identified. So when you guys go with rheumatology with Dr. Ovalle next spring, you'll learn more about lupus and all these rheumatic diseases, and you'll see what goes on with the antibodies that you can measure in the blood to see if they have lupus or not. So these antibodies that we can detect in the blood will combine with the antigens, and that causes our immune complex to form. Yep. And then finally, wherever those complexes become trapped in the tissue, that's where you're going to have your symptoms. Okay? Now, with lupus, usually it's going to be a type 3, but sometimes you could have type 2 reactions as well. Type 3, is that going to affect more your organs, tissues, or the cells? Type 3. Organs, because those immune complexes get lodged inside the tissues and they cause organ problems. You also have autoantibodies against cell surface antigens, white blood cells, red blood cells, and platelets with lupus. If you see any type of red blood cell, white blood cell, platelet issues with lupus, those are cells, right? So it has to be a cell-mediated issue. So they get type 2 as well. The majority are type 3, but they can get type 2. So let's say they had a type 2 autoimmune hypersensitivity reaction with red blood cells, and they're attacking the red blood cells. What would you expect to see on a lab report of their CBC? Anemia, because their red blood cells are being destroyed because of the lupus. So you draw their blood, and their hemoglobin comes back at like 10. So you know their hemoglobin's low, their red blood cells are low because of the lupus due to the type 2 hypersensitivity reaction because it's attacking your cells. Whereas type 3 is mainly going to be more for the tissues. Okay? Make sense? Okay, so that's pretty much it on lupus. This last little bit here, we'll talk about HIV/AIDS. So remember, we talked about with regards to immunity, either you can have a hyper response, which are the 4 we went over, or you could have a deficient response. That's where acquired immunodeficiency syndrome comes into play. It's the most advanced, most serious stage of HIV. So you can live with HIV for many, 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 many years. You don't become full-blown AIDS until your CD4 count drops below a certain number. We'll get to that in a second. So it's a secondary acquired immunodeficiency characterized by defect in cellular immunity. You can't fight off infections anymore. That's why I said the other day in class, people with HIV/AIDS usually don't die from AIDS itself. They die from an opportunistic infection. An infection that has an opportunity to take over now because of your weakened immune system. Okay, low CD4 helper T cell. Remember, the CD4 receptor is only on the helper T cells. The killer T cells, what receptor do they have? CD8. So that's why we only look at CD4. Remember, CD4 are the helper cells. They're the antigen-presenting cells. If you don't have a lot of those, your immune system is weakened because your body doesn't know what it's fighting against, because you have a deficiency in your helper T cells. You also get a reversal of normal CD4 to CD8 lymphocyte ratio. Again, that's helper to killer cells. There are 26 conditions that are common with advanced HIV disease. Again, but they rarely occur in healthy people because they have a very, very weakened immune system. Transmission, sexual contact, sharing needles, perinatally from mother to baby. These are all ways that HIV can spread. And then if you want more information from the CDC about AIDS, HIV, there you go. So HIV infection may present with fatigue, pharyngitis, myalgias, rash, lymphadenopathy. What does that sound like? Everything, right? So what kind of questions, if they came in, I got a fever, my throat hurts, I got body pains, I have this rash now. What kind of questions would you want to ask in your history to find out, is the likelihood of this patient having HIV/AIDS is up or down? Sexual history, right? Ask those questions because find out, because if they say, oh, I'm celibate, I practice safe sex every single time I have sex, I don't do IV drugs, is the likelihood of that patient having HIV higher or lower when they respond that way? Lower, right? So one of the things you're going to learn this semester is when someone comes in with a symptom, what are the diseases that fit that symptom? And we're going to list them on the board. So like for the cardiac one, it'll be like they come in with like chest pain. So what are all the things that have chest pain in them? And we're going to list them on the board. And as you go through your history, you're going to rule out and rule in certain diseases based off of what you found out in your history. You could put everything under the sun in a differential diagnosis. But this case right here, patient thinks he comes in with these very general complaints. Yes, is HIV a possible diagnosis for this patient? Of course. Is the likelihood there? Probably not. But when you start asking your questions, no, they don't have sex, or they do, they use protection all the time, they're not IV drug users, they're not traveling in other countries. Because they answer no to those questions, the likelihood of HIV goes way down, because they're not answering questions that would lead you to believe risky behaviors to get HIV. So these are some of the other ones they'll get. Fever, weight loss. That's why I always ask about weight loss to your patients. And if they say, yes, I've been losing weight, what's the next question you want to ask that person? On purpose or not? Are you purposely trying to lose weight or no? Because if they're not trying to lose weight and they're losing weight like crazy, now that leads to a couple of different diseases that could be for unintended weight loss. Mouth sores, thrush is a big one that they'll get HIV patients. It's just an overgrowth of fungus, candidiasis. The myalgias, liver, spleen enlargement, and so on and so forth. So these are a list of these opportunistic infections. You can see there's a lot of different forms of pneumonia. These are very, very odd, especially this Pneumocystis jivarosi is a very common organism for HIV/AIDS patients to get pneumonia with. And also this MAC is another one they get as well. And I will say this C. neoformans, the reason why I bring it up and I mention it is because years ago, are you guys familiar with like Challenge Bowl at FAPA and the APA conference? So Challenge Bowl is a big educational question and answer, like the Challenge Bowl. All the schools compete, everyone has teams. So all the PA schools across the country compete. Last year we got second place out of all the schools. But the reason why I bring up this is because years ago for the FAPA Challenge Bowl, the C. neoformans was actually the answer to the question, to the Challenge Bowl question, so I just mentioned it because sometimes they ask these weird oddball diseases that cause pneumonia, and that's one of them. Oral candidiasis, that's your thrush, the white patches in the mouth. Hairy leukoplakia has to do with the white blood cells. Infectious enterocolitis, so we get some GI problems. CNS issues, central nervous system, toxoplasmosis, and AIDS dementia complex. Again, these are things that do not happen in normal people. It happens in HIV patients because they have a very weak immune system and they can't respond to normal things. In the peripheral nervous system, they get an ascending polyradiculopathy, and they get some retinitis. And the last thing is cancer, Kaposi sarcoma, which is what that picture is showing. This is a manifestation of HIV called Kaposi sarcoma. These are cancers. So if you see that on someone, that usually means, again, normal, healthy individuals do not get that. And if you see that, you better start thinking about HIV very fast and getting those blood work done to see what's going on. So AIDS itself is a lentivirus that started with animals. There's a long-term latency, so you may not even know the patients have it for years. They may have been exposed years ago, and then there's a long latent period before anything starts really happening, usually about 10 years. What's going to happen? Fatal, slowly progressive diseases, immunodeficiency states, wasting syndrome. They start losing weight like crazy, all muscle mass goes away, and CNS degeneration. HIV will only infect anything with a CD4 receptor. So what has CD4? Obviously, we have our helper cells, macrophages, dendritic cells, natural killer, microglia. Those are all of our immunity cells, right? Those are all things that help us with immunity, and now they're all deficient. And they all have CD4 receptors, so they're all going to be infected with the HIV virus. So losing all those CD4 cells causes autoimmune destruction, viral infection destruction, and then obviously toxicity of anything with a CD4 receptor, and then obviously apoptosis, cell death. It causes cell death. Why does it cause cell death? I'll get to that in a second. But basically, remember, this is a virus. All viruses do, they inject a cell, they replicate inside that cell, and then they cause the cell to burst, and all the little viruses inside now get released, and they go infect the next cell. And each of those cells do the same exact thing, replicate inside, build up all those viruses inside, burst, and now all those HIV viruses are floating around to infect the next, and so on and so forth. So clinical manifestations, these are the signs and symptoms they may get with HIV/AIDS. Fever, fatigue, unexplained weight loss, again. That's why I always ask about, in your general survey of the patient, any unexplained weight gain or weight loss. Lymphadenopathy, and then here are your opportunistic infections. Again, pneumonia, usually the things that they're going to unfortunately die from: pneumonia, toxoplasmosis, CMV, retinitis, stuff like that causes a lot of problems. Okay, we're gonna stop here, but I'm gonna start cardio in a minute. I'll publish your lecture. So